can imagine that it's impossible to speak 15 minutes on all possible extracardiac anomalies detected at this stage. But just at the beginning, I want to emphasize that the main sentinel sign leading us to most fetal anomalies in the first trimester are either such high drops or signs of high drops or the thickened nuchal translucency, because you have seen not only chromosomal anomalies but also many cardiac and extracardiac anomalies may be associated with these signs. Now, if we look at the fetal echo indications, that means the indications leading to a referral at early gestation, we have heard that these three, that means the thickened nuchal translucency, the reverse wave in ductus venosa and tricuspid regurg, are highly associated with the cardiac problems. But also it's known that associated anomalies found on ultrasound are already an indication to perform a fetal echo. And if these are detected in early gestation, we can do it. It has been several times we have quoted that family history is already an indication in many consensus to check for the heart in early gestation. And there are some maternal diseases or drug intake or especially obesity. You may be lucky to have a look to the heart sometimes or to the fetus at 12 or 13 weeks, which could be easier done than at 22 weeks. And the question is still couldn't be answered yet whether one of these days will go toward early screening. Now, how to approach the first trimester systematically, not only to perform the measurement of the nuchal translucency and nasal bone and so on. I think it could be worth to do a comprehensive biometry to look at the nuchal translucency, ductus venosus, and additional signs, to look at the brain and the intracranial translucency in longitudinal and sagittal view, the same for the face, the same for the abdomen, to look at the stomach, the attachment of the umbilical cord, to look at the filled bladder, and if possible to have a look to the kidneys, to look at the spine. I prefer to do it rather coronally than longitudinally, and then arms, legs, and hands and feet. And of course the heart, including the ductus venosus connection, the aberrant subclavian, and last but not least the placenta, and if by using color Doppler you can see the attachment of the cord. Now it seems very long, but we are doing this every day at 22 weeks, and it's only a question to think about it more systematically when you magnify the image. Now, I will not be able to cover everything, but I think what we have in a standard system of reporting is, besides the CRL, the head size, the abdominal circumference, and the femur, and sometimes adding the humerus to it. When we look to the brain, I told you yesterday that we look at a longitudinal view, but mainly also transversal view. And I tried to get a profile of the fetus, not only to measure the nasal bone, but to get an impression of the fetal face, and then turn the transducer to get different parallel planes to confirm that I've seen two eyes, the nasal bridge and the upper jaw, to rule out some abnormalities of the face. And when possible, I think with 3D you may get, let's say, an approach to the face that you see that it looks normal, especially by looking also to this, to the metopic suture. Now we go a little bit lower to the abdomen. I confirm that the stomach is on the left side, and all these examinations are done generally by transabdominal ultrasound. And for specific questions or in early gestation, in earlier than 12 weeks, or generally I take 60 millimeters or 65 millimeters and less, where I decide to switch to transvaginal. Everything more than 65 millimeters CRL is amenable to abdominal scan, unless where there are objective condition or limitations. Now the filled bladder, the filled stomach, the attachment of the cord, and the filled bladder with the confirmation of both umbilical arteries are standard. Now, in many conditions, I try, mainly when a fetus has a length of 70 millimeters and more, to get a coronal view to confirm the presence of two kidneys by looking to the to the pelvis. But this is the important plane, but we cannot rule out some multicystic degeneration. They may appear, you may see the kidney, but it's not that obvious as in later gestation at up to 17 weeks gestation. Now, rarely I add the color Doppler to confirm this, because if you don't see it on 2D, you may see anything with color, but when you have such a good visualization, you'll be able to confirm this. And then the 4-chamber view, I'll try always to get the lateral view on 2D and apical view on color Doppler. And I concentrate mainly on the 3-vessel trachea view, showing that the normal size of the vessels. But I'm not always getting the short axis and the 5-chamber view on every fetus. And probably I will be missing some tetralogy at this stage. Now, the spine, if the fetus by going transvaginally looks like this, I can have a look, of course, but generally I look at the spine this way, demonstrating the ribs, and sometimes I can have a look to see whether the ribs are present on both sides, or as you may see here, if one side could be missing, and then I will go to look at the arms with the hands, the legs, and in this way and that way, and try to show the mother by showing this way that there are two, because if you show the hand and you show the other hand, sometimes it can happen to you that when she's leaving the office, she asks you, but you were sure that there were two separate hands, or was it the same one? And this is why she may lie again. And this is why, since I heard the 3 times, I show them in a cross section. You see both legs and both arms, and then I try to look at the foot this way to rule out any ectrodactyly. Now, when possible, when you have, we may have a look at 3D, you may have a total, let's say, view to the fetus, especially for the limbs. It's of big importance. In early gestation, it's not good to cut the legs. You can do it at later gestation, but you may be happy with the face, but be sure that the lady will come back and say, I didn't see the legs. Are the legs there? Because they are not on the picture. Now, what are the anomalies detectable in early gestation? But I will not cover all. I will cover mainly the one where you may be thinking on looking to the heart, or you may be expecting to see some cardiac abnormalities. Fetal hydrops, as in this condition, when you see some hydrothorax, this is very suspicious to be Turner syndrome. Then you look at the heart and you may see some discrepancies of the chambers. Yesterday, I covered comprehensively the complete intracranial anatomy and abnormalities, but I think holoprosencephaly in early gestation is the leading sign of trisomy 13, which is known to be associated with cardiac anomalies as well. And another approach is the one to the face, and you see here some facial clefts combined. And this case was also combined with the pulmonary atresia. It's unusual, but the combination of facial anomalies and cardiac abnormalities are not only present in trisomy 13, but could be also a sign of microdeletion 22, but also a combination with pure cardiac anomalies. Now, of course, when you look at the abdominal wall, it's easy to detect such a large structure as the liver in an omphalocele. In abdominal wall defects, actually, except the gastrocesis, not associated with cardiac anomalies. When you think about the omphalocele, there are 3 groups where you will check for the heart. The first one is this one with the large omphalocele. They are known to be associated in 20 to 30% with cardiac abnormalities. And there is a smaller one like this one, rather associated with cardiac anomalies within the spectrum of trisomy 18. And the third one, where you have the impression that the wall defect is a little bit higher, then you have to check for the combination of pentalogy of Cantrell, where the heart may be shifted and the pericardium or part of the pericardium and the diaphragma may be affected. This is why the higher abdominal wall defects are also an indication for fetal echo. Now, when we look to the stomach, I think 2 points should be emphasized. The first one, to demonstrate whether the stomach is not in the chest, but this was at 13 weeks. But most cases are not as obvious with the heart shifting, but you may see the heart starting to shift and you see the stomach a little bit higher. This is tricky, and it's not evident to diagnose easily diaphragmatic hernia in early gestation. Probably longitudinal view may be of help. And the other point is, of course, if you do it systematically, especially by transabdominal approach, is easier than transvaginally, to demonstrate that the stomach, as in this condition, is on the right side, and you see both vessels here. After you have known that the stomach is on the right side, the heart was abnormal, then you may see that this is the juxtaposition in the case of right azomerism. Or you see like this, you see an abnormal heart on the four-chamber view, and the fetus is moving, and you stop the image, you go to the upper abdomen, and you see this, and this is already an easy abnormality to detect, but not that easy to diagnose what is the underlying condition, whether it's azomerism, left and right, and so on and so on. But this is the first aspect. You see the abnormal heart, or you see the different position of heart and stomach, and this is a leading sign. Now, when we go to the lower abdomen, I showed you the three signs we need here: the full bladder as sign of functioning kidneys, both umbilical arteries and the abdominal wall. And from this point, you may see directly whether there is an absence of one umbilical artery. Actually, this is sometimes tricky because some fetuses, they may have a thin one and you may not see it, and at later gestation, at 20 weeks, you see that it's there. But you have to be careful, and in these conditions, we rather use the HD flow rather than the color Doppler. But once you have this sign, this is already an indication for fetal echo, because an association with cardiac anomalies is known as well. And this is the only case I saw in the last years where the bladder was empty and the kidneys were not demonstrated despite normal amniotic fluid, and this was in renal agenesis detected at 13 weeks, and then we were witness of disappearing of amniotic fluid until 17 weeks gestation. But these are the findings leading to an additional examination, not these huge megacystis mainly related to renal problems, but rather this megacystis where you may think it could be associated with chromosomal anomalies. Then I will look to the heart and other renal signs as the P. electasis in early gestation, which was also associated with let's say increasing risk for trisomy 21 according to Kipros studies. Rarely, but this is when you have several subtle signs of abnormalities. You may look at let's say whether there is a junction of the kidney, and this was a fetus with a thickened nuchal and additional signs of trisomy 18. And we could see here the horseshoe kidney. Horseshoe kidney is a typical sign in trisomy 18 and in Turner syndrome. That means when you have a suspicious for this and look at the kidneys, this is what you may look for. Sometimes you may have a referral because of a big cyst in the abdomen. In these cases, we are more optimistic. Of course, we offer the CVS and cystic fibrosis diagnosis in the parents, and we do CMV diagnosis, but all cases we have seen until now, and I guess we have something like 5 or 6 disappeared in the second trimester. This is the same case at 16 weeks. You see only an echogenic dot remaining from this cyst. I didn't touch it yet. I told the mother until 20 weeks, but if it's growing, we may think about some invasive things, and then it disappeared, as you see. The ductus venosus is used to get the normal flow in the fetus, and don't do it blindly. Try to magnify the image to see whether the ductus venosus has a normal connection, because you may detect also some anomalies of the connectioning of the ductus venosus here inside toward the inferior vena cava. And some of the cases were reported recently by Acheron and co-workers are also associated with trisomy 21 or also with cardiac anomalies. And this is the same fetus at 17 weeks, and you see the direct connection here toward the inferior vena cava. This is the IVC, and as soon as the umbilical vein enters, you see the higher flow leading to a dilation. You will not see it easily on 2D if you don't look at it with a targeted question in longitudinal view. Now, limb anomalies like ectrodactyly are rarely associated with other, let's say, intracardiac anomalies. But polydactyly is actually one of the most difficult signs to have differential diagnosis. Of course, you will think it could be sign of trisomy 13, but it could be also many other diagnoses. And I think in limb anomalies, you may see them sometimes easier in early gestation if you look at it in magnification and by combining with the 3D. You see here the hexadactyly, the ectrodactyly, and you see at 11 weeks in a fetus with a thickened nuchal, suggesting the presence of trisomy 18, the radius aplasia. Now, why do we measure routinely? This leg did not appears a little bit odd, but if you perform measurement, you see that at 6.4 is really low. And this was a twin pregnancy. Referred because of a suspicion of conjoined twin at 9 weeks, and we've done again at 12 weeks or 13 weeks in monochorionic, monoamniotic pregnancy. And this is what I called the BAM back at 13 weeks, and this is the shortening of the limbs. And then later on, we could see the polydactyly. And by doing molecular genetics, we have found Ellis-Van Creveld syndrome. At the heart, it was at 15 weeks, we could only recognize the echogenic dot. But otherwise, Ellis-Van Creveld is one of the rare skeletal anomalies combined with cardiac anomalies. And there is something not very popular in fetal medicine or not very known. This is a fetus referred at 13 weeks for nuchal translucency. You see here the nasal bone very nicely. The nuchal was not thickened. The intracranial translucency nicely. But afterwards, you may see that we have here 6 fingers. So, and then I look at the heart because, as usual, and you may see some discrepancy of the chambers. And in one of the planes, I had the impression by looking at the lateral view that there is a VST. I try hardly not to write sometimes that there is a VST because I personally do not believe that we could easily see such, because this is rather an artifact for me than VST. But since the great vessels appeared abnormal, later on I wrote, of course, it's a VST. This is the 3-vessel view, or attempt to get the 3-vessel view. And there are this is transvaginal approach, some abnormality here. The first one is we don't see pretty nicely the aorta in this view. And secondly, you don't have the impression that there is some tissue between the sternum and this vessel. And this is here the part of the aorta, and there is an interruption of the aortic arc compared to the normal find. Of course, on a still image, you may say, well, and then we offered the CVS, and it was a microdeletion 22q11. And I had a patient many years ago. She had a child with the hexadactyly, and when I was asking Dr. Rauch, the one who published the big study in European Journal a couple of years ago, they had 5% having polydactyly, having microdeletion, which is not very known, but geneticists, when you ask them, they say, every anomaly can be associated with microdeletion. But in that case, it was, let's say, the first symptom leading to this targeted examination. So I come to the end. I hope that you got the message that you can perform according to the FMF standard nuchal translucency and other measurements. But I think at early anomaly scan, it's easy to diagnose anencephaly, hydrops, omphalocele, and megacystis. But it's challenging also to seek for some typical signs. And this is a question of training on adjusting the machine. But I think the future is rather for getting a systematic approach, plane by plane, to check every single structure, how we are also doing for the fetal heart. I thank you for your attention, and then I will invite